Thanks for having me. It's great to visit the Netherlands. I have very good friends here. I see some for previous researchers in Mass General. We have a nice collaboration with the Netherlands, so this really feels like a second home. I wasn't sure who was going to be an orthopedic oncologist, who wasn't going to be. So I wanted to put things a little bit in perspective in case there is somebody that is not in oncology or is in the industry, kind of like to clarify what we do. So as orthopedic oncologists, we treat primary bone tumors that can be benign or malignant, and you see a list of them. We also treat soft tissue tumors of the extremities and the spine and the pelvis, and we also treat patients with metastatic disease. And in many occasions, we as orthopedic surgeons are the ones to get the patient with the metastatic disease. The patient doesn't have any idea it has cancer, then breaks the leg or the hip with no fracture, and then next thing the patient finds out that there is some sort of primary cancer somewhere else that has gone into the bone and has caused the pathologic fracture. So in all this scheme of type of practice that we have, there are like different instances in which we can use this type of implants, and I'm going to discuss some of the cases and the principles that we follow for orthopedic oncology. So we have seen this in terms of the progression of the material, so I'm not going to elaborate on that. The main advantages have been discussed already. Basically, there is a higher modulus of elasticity, and I'm going to present a case where I think that played a role in the patient feeling a little bit better. There is a decrease in the artifact when you're visualizing the implant. On x-rays, you see less scatter and artifact on CTs, on MRIs, and especially the biomechanical advantage of superior fatigue. So we have seen this previous studies that have been published showing the improved modulus of elasticity, some curves showing the improved fatigue strength, which I think is the main property of these implants, the comparable bending strength, which is okay. So primary malignant bone tumor, so the most common one that we get is osteosarcomas. So there is a nice pathology slide on that to keep it oncologic. So you see the malignant cells producing osteoid there. It has a bimodal distribution, so you can see it on younger patients and older patients. On x-rays, you're going to see this periosteal reaction. There is a nice example there of a sunburst periosteal reaction. And on MRI, you're going to see this hyperintense lesions on T1 and hyperintense on T2 with heterogeneous captation on contours. As all of you know, they can metastasize to the lungs, they can metastasize to the bones, and we usually do the workup for that. For follow-up, in terms of treatment, this is kind of a standard. You do a preparative chemotherapy, you do your resection with wide margins, then you continue with your chemotherapy, and then you can reconstruct your defect in two ways. You can use osteoarticular allografts or intercalary allografts, biologic reconstruction, or you can use endoprosthesis, or in other locations like the tibia, you can use alloprosthesis, which is a combination of the two. Ewing sarcoma is another condition that we see as a primary bone sarcoma. It's more common in children, so this one has the all blue round cells. It has a typical translocation for which we use the in situ hybridization. You see that it's more common in white males, and it has also a periosteal reaction, but this one is more characteristically like the onion pattern scheme. And MRIs look similar. You're going to see a hyperintense lesion on T1, hyperintense on T2, and some heterogeneous signal on the contrast images with some soft tissue component. They can metastasize also to the lungs. PET-CTs have become the standard of staging, and treatment is also adjuvant and neoadjuvant chemotherapy with resection with negative margins or radiation therapy or combination on those depending on the location, but I think in the extremities most of us will agree that surgery with resection margins is the way to go, and the reconstruction has the same options. You can use allografts, you can use endoprosthesis. Chondrosarcoma is another famous one. You see here the slide producing malignant cartilage, affects mostly adults. Most common location is the pelvis. And there are some examples here of how you can see the soft tissue component part on MRI. They can metastasize to the lung and bones. And PET-CTs are taking or making traction, especially in the differentiation of low-grade chondrosarcomas and chondromas. There is some new research on that. Then surgical treatment is also going to be mainly surgical treatment. There is a role for radiotherapy in difficult resections, and with new markers that we have for IDH2 receptors, there is some new promising studies in terms of chemotherapy. So now let's get to the meat of some cases. So this is a lady that presented with pain in her thigh. Her x-ray demonstrated this minor area of change in the cortex, and then a subsequent MRI demonstrated this large lesion in terms of soft tissue involving the bone. This was biopsied and proved to be an osteosarcoma. This was originally a patient of Dempsey Springfield, and he decided to do an intercalary allograft. Double plating technique. 2010, you see areas of junction. These things take forever to heal, but finally in 2014, you see that there is good incorporation of the allograft. So Dempsey Springfield retires. Well, these are titanium plates, and the patient started to come complaining of pain in the leg. She doesn't feel that great, and there is maybe an area of loosening that you see around that screw that raises the concern of a fracture, but she still can't bear weight. We get a CT scan, and then we identify a fracture of the allograft, and then we have to change the whole allograft. In my experience, the results in the long term with intercalary metal prosthesis are extremely poor, and this patient is basically disease-free, is a cancer survivor. And overall her health is good, and she's not on chemo at this point, so an allograft will be an option and could heal with a better chance than it did when Dr. Springfield did this. But the patient didn't follow the recommendations in terms of limiting her weight bearing. She didn't want surgery immediately. She needed to plan her agenda and be sure that the surgery will happen when it was convenient to her. And she came with the plate bent, and then this is what we did. So we found another allograft. I prefer to fix them with a nail in plates at the junctions for rotational control instead of a double plating technique. And this is a 6-week follow-up, and this is a 3-month follow-up, and she's walking, moving around, weight bearing as tolerated, and she thinks that her legs feels much better than the allograft that she had before, and I think that has to do with the modulus of elasticity. I think she had a very rigid construct before with the 2 plates, and it's kind of like a subjective measure, but that could be, I think, a reflection of the modulus of elasticity. I have another patient of his. He loved allografts, so this is an intercalary resection for an osteosarcoma as well. The patient was having pain. There was like some loosening of the hardware, but not really evident on x-rays, but clinically that's what it seemed to be. I got a bone scan, and it shows some areas of activity, but the patient didn't have any markers of infection, or her blood work was normal. So I decided to take her for revision of this. And as soon as I opened and tried to remove the screws, all of them were broken or weld, and that's why she was having pain. And it was very painful to remove, as Professor De Gistro was mentioning. There is a part of a screw that I just left in place because it was harder to, and more morbid to remove than leave it in place. But I use the same technique here. I use an intramedullary nail, radiolucent. I was worried about the allograft. This patient is not very compliant. So I decided to transport her fibula to bridge all the proximal, her own bone with the distal part, and kind of to increase the area of biologic reconstruction. And she sustained a fall, And she had a unicortical fracture of the allograft, but has not progressed, and I think it didn't break because of the nail, which I think probably with a plate it would have failed. One of the other issues that, or scenarios that I mentioned that we treat are malignant soft tissue tumors. There are a rare condition. The most common ones are liposarcomas. They occur more on males. The thigh is the most common location that metastasize to the lungs, and some of them to the lymph nodes. And depending on the histology, we use different staging techniques. For those that go to the lymph nodes, we tend to use PET CTs. Very important to get also X-rays. Automatically, you think it's a soft tissue mass. The MRI gets ordered, but you always can see calcifications in synovial sarcomas, like in this case, and the X-ray can give you good clues. In terms of the imaging, all of them look the same. You need a biopsy to determine what you're treating. So there are hyperintense on T1, hyperintense on T2, and heterogeneous captation of contrast sequences. I think we have switched the pendulum to preparative radiation, followed by resection with negative margins, followed with additional radiation if you have a close or a positive margin. In some instances, in some histologies and age groups, chemotherapy is indicated, so synovial sarcoma in younger patients, for example, rhabdomyosarcomas, but surgically the main goal is to obtain a resection with negative margins. So this is kind of like of the examples of the resections that we do, and you see how the bone gets exposed and the bone gets radiated and the periosteum gets removed. You have to do flaps like this to protect the bone in terms of soft tissue, but you also have to protect the bone mechanically. And this is one of the cases that Professor De Kistro was mentioning. So it's a patient that presented with a myxoliposarcoma of the leg, very large. You see here the axial imaging on T1. You see it better here on T2. It's compressing but not really involving the anterior tibial neurovascular bundle. This is all pre-chemo. The patient underwent treatment with radiation and chemotherapy, had a good response. But to get a good margin, I have to take a periosteum of the tibia and a little bit of a sleeve of the bone of the tibia. And then I protected his bone with a radiolucent nail. And then this is a follow-up MRI, and then it's nice because you can see what is happening, and when the patient is anxious and asking you, like, is it back or is not back, or what do you see, you actually can tell them, I can see that there is nothing so far. The last scenario is a metastatic bone disease, and this is a problem that we're going to have as orthopedic oncologists and just general orthopedic surgeons. The numbers of patients continue to increase and the modalities of treatment improve. We have a lot of patients that live chronically with metastatic disease now. Multiple myeloma is becoming more a chronic disease. So there's going to be a large patient population on this, and this is a useful tool for fixation of fractures. So just remember that thyroid, lung, breast, renal, and prostate are the most common histologies that go in there. Remember the caveat of the resection with negative margins of the metastasis in patients with oligometastatic disease when they have thyroid carcinoma, renal carcinoma, if they have papillary thyroid carcinoma. And I think that's a situation where you can actually, with these nails, do some en-bloc resections and reconstruct them with intercalary allografts and fix them with the nail and a plate, given the high rates of failures that you see with intercalary metal prosthesis. So in terms of the imaging that we get for these patients is basically X-rays, bone scans, PET CT is gaining traction, especially in metastatic lung cancer. And basically the treatment is either the treatment of the fracture or the prophylactic treatment of the fracture, and again can be an intralesional solution like this, or en bloc resection with negative margins, depending on the histology, like in this case. So this is case number 4. This is an impending pathologic fracture of the femur in a patient with metastatic breast cancer, very extensive disease, very short lady. And I presented this case because it happened that intraoperatively she had intraoperative fracture, but we will insert in the nail. So you can see it there. If we will have that happening with the traditional titanium nail, you will have not seen it. Did that change the management of the recovery of the patient? No, but she had a significant amount of pain post-op because of this fracture compared like if she would have not had the fracture. So this is something that doesn't happen that frequent, but I think is a good example to show that you actually can see how the bone is reacting when you're inserting the implant, especially in patients with extensive disease. So you see a fracture there. You see a great modulus of elasticity. She's on chemo and she already is forming some callus. This is a 6-week follow-up and she's doing well so far. So those are like the scenarios that I see where we could use this type of implants. I will add the really important aspect of collaboration between different institutions. We may be one nation, but we look more like the divided States of America and the United States of America. And the volume is an issue, and unfortunately, especially in the setting of metastatic disease and even primary bone sarcomas and soft tissue sarcomas, the care in the United States is not being centralized. I think we're training a lot of fellows and a lot of hospitals are trying to have like their little cancer center. So they take care of the straightforward distal femur replacement, straightforward proximal femoral replacement, straight soft tissue sarcoma, and then to the tertiary centers is all the complications and cases, infections, all the things that they don't want to deal with in these smaller centers. And the problem is like if you don't have the infrastructure for the research in those centers, those are cases that are lost, right? Like the patient that gets a standard osteosarcoma, good reconstruction, does well, and doesn't go to the tertiary center, gets lost in the community cancer center, and that really affects our research. So I think we have to do better work in, if not centralizing, bringing those smaller hospitals to the table and really come to terms to generous research and just collaborate. You know, the authorship at the end of the day is not the priority for patients. Thank you, everybody.